Welcome, Health Impact audience. We are now going to be talking about a very important topic, and that is all the benefits that we've seen from telehealth, telemedicine, remote patient monitoring, all these things that during the COVID era has really picked up steam. Everybody's thinking that we're now in the tele era, and of course, that's not quite true. There's still a lot of learning that is going on, and one of the biggest learnings is that this era is not going to be about telehealth. It's actually about digital healthcare. And what is the difference between digital healthcare versus telehealth? Is it terminology? Is it just, are we calling it something different to make ourselves sound smarter? That's the kind of stuff that we're going to have our two very illustrious speakers coming up next, David and Mary Jo, talking to us about what does it mean to go from just telehealth into true healthcare in a digital age, from a workflow perspective, from a tooling perspective, and a variety of others. So David's going to take over.
Thank you, Shaheen. And I'm David Burek. I'm a partner with Guidehouse. I'm responsible for our payer-provider practice. I do a lot of strategy work, and my long-term clients include places like Cone Health. And let me introduce my colleague from Cone Health, Mary Jo Cagle.
Other than I was in private practice for a long time before I entered into administrative work. So that's why it's so near and dear to my heart, David.
So with that said, I'm gonna drive right into this. Quickly, I think most folks are aware of the major impact which we're all experiencing and continue to experience. I think it is important to note much of the talk in the press has actually been about hospitals and inpatient care, but most telehealth, not all, but most telehealth that we've seen is about outpatient care. So visits to physician offices are down as much as 6%. Declines in physician revenue are down as well. And a lot of the telehealth that we've experienced is actually substituting, augmenting, or replacing physician office visits. With that said, it's interesting in our industry how we went from apologizing for how long it took for us to go digital to overnight saying we're digital and it's all done already. And so you will see, and I'm sure during the course of this series of presentations, this seminar, you're going to hear lots of statistics about how telemedicine and digital health has just boomed. So we're seeing a dramatic increase in adoption rate. The question is, does that last beyond the pandemic? And if so, in what form? So Mary Jo and I tried to apply our collective wisdom to the facts of the case. And this is our point of departure for the presentation. So, telehealth and digi-health volumes may in fact dip post-recovery, but we believe that telehealth is here to stay, but to what extent and how complete the adoption is what we're going to talk about. The second point, it's very important to remember that part of the reasons we had this surge, this spike in telehealth use, was because regulations were suspended. So a key question is, of all these regulations, and some are state, and some are federal, and some are payer related, are they going to just return, or will the suspensions, like in the case of Medicare, become permanent fixes, or will we look at regulations to make them pro telehealth? So what's the arc of regulation? Third point. For certain payers, for certain things, there was actually reimbursement parity for e-health visits. So a provider would get reimbursed the same for an e-health visit or a telehealth visit as for an in-off visit. That was a relatively new and novel situation. So where the reimbursement rates settle down for telehealth is an important consideration. And whether it's in a fee-for-service system or in a risk-based system is a very important consideration. Fourth point, that we couldn't help but notice that golly gee, patients may actually prefer this, or some patients may actually prefer this for some things, particularly from a perspective of accessibility. We noted with some surprise that some caregivers actually are making the transition and want to do more of this as well. And the next two dot points are really about telehealth and e-health under a fee-for-service system versus under a risk-based or value-based service. I think traditionally under a fee-for-service system, telehealth was looked at as an ad. We're going to do everything. Oh gosh, and now you want to add 2 telehealth visits. So the structure was, what do we need these for? In a risk-based, it's like touches are really important, and keeping people out of the ED is very important. So we think that the reimbursement model you're in will affect your rate of adoption. So you put all that together, a lot of words, but the parting comment is consumer preference paired with regulatory and reimbursement support will expand the business model for health systems, as well as introducing new competitors. So from our perspective, this is less about the enabling technology than it is about the enabling regulatory and reimbursement. And what's realized, if that is healthy and sustainable, there'll be plenty of non-health systems trying to get this same business. So with that all as a context, let's learn about Cone and how this is playing out in Greensboro, North Carolina. Mary Jo?
Thanks, David. So I'd love to introduce Cone Health to all of you, just to set the context of the work that's been going on recently. We're a medium-sized integrated health system. We're integrated both vertically and horizontally. Not only do we have several hospitals, we have 6 that are fully part of the system, but there's a 7th hospital that we manage through an MSA. But we also have 150 practices that are employed with employed physicians. We have, in addition to that, one of the highest performing next-gen ACOs in the country that is made up of not only our employed physicians, but a large network of independent physicians across 4 counties. In addition, we have, over the last 3 years, started a Medicare MA product, because we really want to be a disruptor and take out the middleman, because we're really committed to value. And so through that, we've really began to try to see, how do we lower the cost of care for our community while improving quality? And we have, to a great extent, been able to deliver on the quality, as I'm going to show you. We have been able, over the past decade, through a wide variety of external evaluators, been able to establish that statewide, regionally, nationally, and even through Newsweek internationally, established that our quality is among the best that the nation, the world has to offer. And now we're really on a journey to show, can we lower the cost of care? And so we've really begun to put together a digital strategy, because we've been convinced that's one way to increase access and begin to lower the cost of care. And all of these pieces that you see here, the integrated digital strategy, personalized care, telehealth, provider engagement, the reimbursement strategy, we've began to put that roadmap together. But I would say the pace of that was rather glacial. And then COVID happened. And that made us stop and have to immediately turn on a dime. And not only did we have to reset, we had to accelerate. What I'd like to share with you here is really what had happened with our virtual visits. The reason that you see no green prior to March is the green represents the percentage of our face-to-face visits in our physician. The green is the virtual visits in our physician offices. The orange represents face-to-face, and they were so minimal that it didn't make sense to even put it there. When COVID hit, we increased it to 15% in March, and you can see by April they were up to nearly 70%. The other data that I want to show you there is that on our patient satisfaction, our HCAP scores, we've always done well. You can see that we were in the top decile. That's the blue line. But the surprising thing to us is that as we added virtual visits, which made access so easy for our patients, our access scores in virtual visits, which had been just in the mid 80 percentiles, started to rise. 86, 86.9. In June, when we started to introduce more face-to-face visits and the virtual visits dropped to 37%, our access scores, satisfaction with access dropped. By the way, in July, we started increasing virtual visits again because we got the message. So, I want to quote Seema Verma when she said she thinks the genie's out of the bottle on this one, and I agree with her. I actually think she was quoting me because I don't think there's any going back. I think that our patients, our customers are telling us that they want virtual care. Whether it's virtual visits with their primary care physician or with their psychiatrist or their cardiologist or with their PT and OT. Those are just some of the ways we're delivering it. We're also delivering it in urgent care, in the ED for screening. We have looked at all the different ways we can do this, and as front door for registration. And we have a site where people can go to determine where they need to go for care. So we are really looking at a strategy to provide a directional way for all of our patients to get information and know where they need to go. And in fact, all of our COVID screening can be done online and virtually. So in light of that, we've really had to look at the complexities of how our patients and providers have that experience. And it has raised a real debate for us within Cone Health about what our strategy needs to be. And our IT team, working with really renowned people in the industry, has come back with a really wonderful roadmap that talks about how we get various certifications at various times. And this really, what I call an unplanned tension, has arisen because our providers are saying, yeah, but that looks difficult, and what I'm doing now is easy. I had a great conversation with one of my psychiatrists who said within 24 hours, she went from 100% face-to-face visits to 100% virtual visits. And I said, how in the world did you do that? And she said, I downloaded DoxyMe, and I called, and between myself and my office team, we converted all of my patients to Doxy.me. Well, that was not on the IT roadmap. but it worked for her and her patients. So there is this, I would say, probably healthy tension, but yet tension between what our providers are trying to make easy for their patients and their need to provide care, and the necessary complex roadmaps our IT teams and vendors are putting together. And I think it's a tension that we've got to resolve, because we've got to remember that our providers are on the front line, and they're trying to make it navigable for the consumers that they're serving. I also think that what we have to remember is we are in a competitive landscape. And I just want to share with you how competitive it is in my part of the world, in North Carolina. This is an eye chart, but it just shows you what we're dealing with here in North Carolina. These are just a few of our competitors. So in care delivery, I've got CVS Health, Iora, Oak Street Health, Blue Cross Blue Shield is getting in the mix. Not to mention my other health systems who are moving in my market. Novant, Atrium, Wake Forest Baptist, Novant has partnered with GoHealth. They're all bringing new innovative products into my market. The state has certain dynamics and pricing pressures. They really are trying to get the amount they're spending on Medicaid even lower, and I would say that's amazing considering how little North Carolina spends on Medicaid. But they've brought up new product, NC Care 360, that they want us to use. Walmart's getting into the picture, partnering with Grand Rounds. And in payer innovation, there's Bright Health, Lumeris, Health Alliance, Haven Healthcare, United. And I think what we know is with these disruptors, our customers, our patients are going to go where it's easy and less expensive. So the onus is on us to create products that are easy for our customers and that are sticky and don't cost them a lot of money. So as we shift our business model, we are starting to reimagine how do we create a strategy that allows us to create easy access that our customer can put on their phone and use easily and want to reuse again, that makes a smooth, easy, seamless experience for them, and will allow us to grow into other untapped markets in the future.
So what this slide tries to establish is that for all the reasons that Mary Jo just gave you, that consumer engagement, where there is the new competitive, where there is the push for market share growth, is a critical area right now. I hasten to add, if you go back to that slide she presented that had the easy button in front of it, there by grabbing a digital customer, it allows the hospital to also embark on a digital transformation of how it sees patients in the hospital in a way that unifies all the data. So while this presentation focuses on that consumer front door that's exploded with COVID, the design which Cone is working on also informs and integrates with all the work that has to go with hospital episodes and making sure the EMRs are making it easier for the caregiver to work. And Mary Jo, are you comfortable making a comment on that side of the equation as well?
Sure. I think there's been a lot written about physician burnout. Physicians are some of the most resilient people that I know, had to be for us to complete our training. And what we've created with the current EMRs that we have are huge data entry machines. I think we have an opportunity to rethink and redesign how we capture information and the workflows in hospital. How can we use a digital revolution to redo that work? We've begun to think about how we reshare that load for our physicians in the hospital.
Thank you. So we thought we should also bring this to have a payer perspective as well. And as Mary Jo referenced, Cone is also a payer and is committed to being more and more of a payer, largely because they believe that allows them to reimburse for more innovative, consumer-friendly, quality-friendly services. And so, but most everybody already has a payer. So what are the payers currently doing, and how does it reflect on this? And just about every payer we work with does have a digital strategy, and many of them are very advanced. But the suspension of regulations and the surge in interest in consumer adoption is also something they can participate in. So does their infrastructure to do things digitally with their members? They don't have patients, they don't have consumers, they have members. So are there telehealth and digital capabilities for members? They're also getting a surge. And do they have the infrastructure to support them technically? Do they have the bandwidth? Mary Jo shared with you some really huge increases in volume. Have payers gotten the same surge? And oh, by the way, do they have the backup and to deal with all this extra volume? And oh, by the way, if they turn it back to providers, are the contracts resilient enough for this new volume to be in place? And for those of you who aren't familiar with the acronym on the bottom of the page, it's per member per month. So what Cone has realized is your digital strategy in a per member per month scenario is different than your per member per month scenario in a fee for service strategy. And it becomes very much entwined, overlapped, competitive with what payers are doing. So we thought it would be good to, from a payer perspective, taking care of their members, talk about what e-health benefits might be the new standard. There is a lot of work being done on wellness today, and they have goals and they have solutions. And there's a lot of work on access. It's funny how much time payers spend on access and how to do it anytime, any place, any time of day. There's also increasing amount of that's being done to coordinate care, and not just from the hospital to a nursing home or to the home, but even to get referrals and specialty referrals. Increasingly, delivery care is important, and everyone's device can now deliver care. And what we are and we are seeing some payers want to have a captive narrow network for care delivered by the device, so that you use the system defined by the payer, not the system defined by your primary care physician. So that's how some of this competition manifests itself. And then finally, just how effectively you pay for care and do your member satisfaction surveys. Is that all going to be done digitally? So the e-health agenda for a payer, there's a lot of overlap with a physician organization and a provider system that has never really been made as apparent as it has over the last 3 or 4 months. And so that's why we thought we should indicate this. And Mary Jo, has this created any conflict at Cone as you are a payer and a provider at the same time?
So it's been interesting as we learn our way through it. what is successful for the payer side of the organization, our ACO and our insurance company, is fewer people in the hospital, right? And so on the hospital side, success has always been about higher volume. And so on the payer side, we're excited when we've managed patients well and we have healthier patients with fewer people in the hospital. And so it's created this dichotomy. And so we are now learning a new normal, which is celebrating wellness and not having people in the hospital, and actually closing some hospital beds. Now we've had to open them back up during COVID, right? And we will until we get this awful virus gone. But there's been that dichotomy of learning how to manage through the old way of doing things in hospitals. But the good news that we've been able to share is this whole idea of providing e-health benefits to our employees and wellness benefits to our employees. And what we've actually seen is healthier employees and our employee healthcare costs starting to level out, decrease utilization of the ED or urgent cares by our employees, and less absenteeism because during their lunch break or their breaks, they just do an e-health visit.
And I don't think this is chiseled in stone anywhere, but I think it's a generalization that one of the ironic changes that's going on here is in the word access. You know, in the past, access meant anybody who needed a hospital could get to the hospital, where access today means anybody who needs healthcare to stay healthy can get healthcare to stay healthy.
Correct.
And digital makes that that's where it's very transformational. So
when they want it.
Yes. So we needed a summary page for all these concepts, and we chose a relatively complicated one. And why? So as health systems go, COVID has tested their resiliency. So some health systems have become weakened in their ability to spend investment dollars to compete with new competitors. Others are in a much better position to grow. So digital health is actually becoming a defining issue for health systems. Their ability, are they going to own and develop, or are they going to partner for telehealth and digital health? Are they going to be able to transform the way they do business to put these applications in the field in a competitive manner? And will they have the time and energy left over to look at their inpatient systems and get a better return on investment for the digital investment there? So we really believe those health systems who have the more reimbursement incentives for telehealth, that are in regions that have liberal or enlightened regulatory, will create great advantage with their tele-digi suites. And since digital is a flat world, you're not limited to Greensboro, Carolina. We're going to see movement that we never saw before. And given that Greensboro is in North Carolina, it's very easy to make a banking analogy. 50 years ago, Charlotte was not a banking center, and today it's a great world banking center. And why is that? The historians tell us that it's because North Carolina was the first state to allow branch banking. So all the hospitals in North Carolina got digital. They got standardized. They knew how to not just have teller systems and a drive-through in the back. And so this, for many of our board members in North Carolina, they understand this change because they've seen it before. And so not to use a battlefield analogy, but just we expect this to be very competitive, and the organizations that can get the right reimbursement regulation in place really have an advantage on a go-forward basis. So Shahid, that's our presentation. I just send it back to you for questions.